Hello, everyone. Welcome to the OPR Leaders Workshop at VitalLink Academy. I'm Dr. Jeongkye Hwang from Catholic University and Division of Vascular and Transplant Surgery, working in the Eunpyeong St. Mary Hospital. Today's my talk is organ procurement process and arrangement, consisting of two 20-minute presentations. In the first presentation, I will cover the following contents. First is the generic considerations of brain death donations. Second is profound effect of brain death. Third is the technical considerations of organ procurement, and I will summarize it. The brain death criteria were established by a committee at Harvard Medical School in the 1960s. Brain death is irreversible loss of brain and brainstem activity due to extensive and irreversible damage to central nervous system following trauma, hemorrhage, or infections. So clinical criteria include coma with cerebral unresponsiveness and apnea and the absence of brainstem reflexes and the persistence of these conditions for 6 hours to 24 hours. This table shows the key points for the clinical diagnosis of brain death. Important prerequisites for clinical determination of brain death include clinical history, known etiology, and irreversible condition compatible with brain death diagnosis, and the exclusion of medical conditions which could influence clinical examination, such as severe disturbance in electrolyte, acid-base imbalance, or endocrine metabolism. Also, exclusion of central nervous system depressant drugs and the exclusion of neuromuscular blocking agents and the maintaining body temperatures above 35 Celsius. The three mandatory clinical signs are Glasgow Coma score less than 4, and the absence of brainstem reflexes, and the absence of spontaneous breathing with apnea test. Ethically sound and technically successful organ transplantation is logistically complex because it includes identifying potential donors and obtaining donation authorizations, determining donor medical suitability, and the distribution of all donated organs. This diagram outlines the brain death donor management process in South Korea. When a potential brain death is notified by medical staffs, an organ procurement coordinator dispatched to assess the patient, consult with medical staff, and confirm donation suitability. After interview with the guardians and obtaining consent, The coordinator informs them about the donation procedures, brain death determination process, and the funeral service expense support with the emotional support. After that, the first brainstem examination is conducted, confirming the prerequisites and performing 7 brainstem reflex tests and the first amnio test. In other patients, after 6 hours, a second brainstem brain death examination is conducted, identical to the first brain death examination and performed after 6 hours for others, and then check flat brain waves for more than 30 minutes. The brain death decision committees that make a unanimous decision to declare the brain death and declare the time of death. Finally, organ procurement surgery is coordinated among the various hospitals. Donors are classified into 7 stages from brain dead potential donor to transplantation donors. Brain dead potential donor means a patient characterized by a Glasgow Coma Scale score less than 4 and the coma mentality with a irreversible brain injury and the no self-respirations with ventilated care. Medically suitable brain dead donors means a brain dead patient with no absolute contraindication for organ donations, transmittable infection such as active tuberculosis and tumors with malignance, with the exception of low-grade central nervous system tumors. The request donors, the donor asked to donate the organ to their family members, and then consent donor is the donor agreed to donate it. The list of donors, organ donors who passed the first brain death assessment. Actual donors, organ donors who undergo organ procurement surgery, including those whose organs are not used. And transplantation donors is organ donors who undergo organ procurement surgery with designated recipients. In 2018, in JKMS, Dr. Lee and Dr. Kim report that organ donors who have undergone organ procurement surgery through the entire management process from identification as brain dead potential organ donors to actual donations, duration 2012 to 2016 for 5 years is just 8.9% in South Korea. The role of the donor coordinate is very important as summarized here. Detecting and identifying possible donors, supporting other professionals involved in the donation process, and supervise the donor maintenance and the serological functional testing in order to maintain good organ perfusion and to the quality and safety of the organs and the tissue for transplantations. And approaching the relative of potential donors and obtaining consent to donations, and overseeing the entire administrative and legal process of donations, including obtaining court orders when required, and then organize the organ and or tissue procurement and distributions, coordinating the necessary and available resources for their procurement, such as operation rooms, anesthesia, nursing, surgical teams, etc., and the subsequent distribution and the transport to their final destinations. Next topic is profound effect of a brain death. This figure shows the pathways by which brain death evoke organ injury. Brain death due to cerebral ischemia lead to three main effects on vital organs. The first is cardiovascular effect. The cardiovascular effect include hypertension or hypotensions due to sympathetic or parasympathetic response. Finally, it damages to the hemodynamic instability, the two damage to vital organs. Second is the endocrine change. The pituitary hypothalamic dysfunctions causes the loss of thermoregulations and the hormonal imbalances, and then it made it hypothermia, hypovolemia, and so on, the hemodynamic instabilities. The third is morphological changes caused by coagulopathy and the pro-inflammatory cytokine release. So to manage this effect, the fluid resuscitations and inotropic support and the hormonal substitutions are required. This table shows recommendations of this donor organ management. Some kind of key points include the maintaining core body temperature over 34 Celsius, and the hemoglobin level is over 7, and the mean arterial pressures 60 to 90 millimeter mercury, and the central venous pressure maintained 4 to 12 millimeter mercury, and the urine output of 1 to 3 millimeter per kg per hours, and the plasma sodium level of 140 to 155 milliequivalent per liters. Next topic is technical considerations of organ procurement in heart beating organs. The basic principles of the donor operation should be performed meticulously, including dissection of the great vessels of the chest or abdomen, isolation of the aorta in preparation for cross-clamping, perfusion and core cooling in situ, and the rapid organ recovery to prevent ischemia. The surgical procedures involve the step-by-step with the warm dissection. First is a general preparation and the positioning of the donor and the draft, and then open the abdomen and the dissection of the distal aorta, dissection of the liver, pancreas, small intestine, kidney, dissection of the aorta on the diagram for suprasellar aorta, and the insertion of the perfusion cannula into the aorta for cold perfusion, and the perfusion was done. And the step-by-step procedures, we will watch a video clip in the next lecture. This figure shows the schematic organ perfusions. Large bore catheter is inserted into the distal aorta for perfusions, and the supraciliac aorta is cross-clamped, and the venting is done via the suprahepatic. The order of organ recovery is critical. Cardiothoracic organs, heart and lungs are removed first, as they are most susceptible to ischemic reperfusion injury, following by the small bowel, liver, pancreas, and kidneys. Each organ's ischemic reperfusion time is heart is the 4 to 6, small intestine also 4 to 6, liver is 12, and pancreas is 12 to 18 hours, kidney is 24 hours. In summary, often in the organ procurement procedures, open the abdominal cavity, inspect the organs, and dissecting the aorta and the large vessels, prepare for perfusion, and the perfusion, performing inside perfusion and cooling, and recover each organ in sequence. This entire process must be done while minimize the total ischemic times. Thank you for listening, and I'm sorry I couldn't attend in person. So if you have any questions or comment, please contact me via email. Thank you.